Everything was bad there?
All right. There are a lot of video. Just start there. Yeah. There are a lot of YouTube stuff that you can pick up on as far as IPV treatments. Let's talk a little bit about the guidelines. When I started in the profession in the late 70s, it was widely overused. It was the primary mechanism by which we delivered medication. We didn't have the handheld, the small volume nebulizers. Rather, we used this. It wasn't until the 80s that we started to see position statements both from the American Thoracic Society as well as the American Association for Respiratory Care developing. And now the problem is that the pendulum has swung the other way, and we're probably underusing it where we should be using it. So again, it goes back to a whole protocolization, trying to get people to do things in a standardized fashion. I will tell you, there are still many, many questions on your board exams dealing with positive pressure ventilation. Okay, so it's not something that's going to go away. It's also a very good lead into mechanical ventilation. So what we're going to cover in the summer, this is a good starting point because it's positive pressure, whether you're doing it using a pressure-based strategy or a volume-based strategy. And I think Lori talked about that in Module B in 1140. In this case, we're using inspiratory positive pressure on a spontaneously breathing patient. Well, technically, they don't have to be, but we're going to use it via a mouthpiece, a mask, or if they happen to have an artificial airway in. On the left-hand side, we see spontaneous breathing, where we create a negative intrathoracic pressure, and that allows volume to enter into the lungs. What we're doing here instead is we're using positive pressure on the right-hand side. We're literally pushing the air into the patient's lungs. So again, looking at, this is a picture out of Egan. You guys remember Egan? Yeah. Spontaneous on the left-hand side, negative pressure intrathoracically, negative intrapleural pressure becoming greater, more and more negative, air rushes in. Positive on exhalation. Here, it's positive on inspiration to the extent that the intrapleural pressure can almost reach a positive value. And on exhalation, it's passive to return back to where we're at. Just like in spirometry, our goal is to increase the inspiratory capacity. Okay, that's still our target. And this is the rule I think we saw when we looked at it in spirometry. If it's less than or greater than or equal to 33 of the preoperative or predicted value, or a vital capacity of 10 to 15 mLs per kilogram, we would look at a spirometry. If we get below those values, now I really need to look at using IPVB as a mechanism by which we're promoting lung expansion. You guys have seen these formulas before. There actually are some other ones that we'll expose you to at a later date just to make life more confusing. But again, we want to be able to get that predicted vital capacity of at least 15 kilos, 15 mLs per kilo, or a spontaneous tidal volume that's twice or 3 times there's normal spontaneous tidal volume. So what about indications? There's 4 primary indications you want to look for. One is an atelectasis that's refractory to incentive spirometry or cough and deep breathing. So if the simple stuff doesn't work, go the next step. Okay. If I have somebody who has an inability to adequately clear secretions because the pathology that they have doesn't allow them to take a deep breath and cough, this would be an alternative that we can do it. A third one is if I need to have medication delivery. Well, small volume nebulizers, meter dose inhalers, DPIs, those all deliver medications quite effectively. But somebody perhaps who has severe bronchospasm where they just can't get the air in, I could push it in. I can use positive pressure to make that medication get down to where it needs to be. Same is true for patients that have too weak of muscles to take a deep breath. So somebody perhaps that has some neuromuscular deficit, or somebody has a chronic condition like COPD that they actually enjoy having their lungs inflated. Enjoy? Maybe not the word enjoy, but it feels more comfortable for them. Same as we had with an MDI or a small volume nebulizer, the amount that we actually deposit into the lungs is very low. But it is enough that we can end up having bronchospasm relieved. Fourth reason for doing it, we don't see that often, but you can mechanically ventilate somebody with a positive pressure machine. So instead of having a big ICU-style ventilator, I'm going to use a small portable unit for short-term therapy. Rarely do we see it used for pulmonary edema. There now is the utilization of non-invasive ventilation that has been kind of supplanted it. But in the old days, yes, we did use 30 to 50% ethyl alcohol, which translates to about a 60 proof. And yes, the patient became very calm. The idea being is that nebulizing the alcohol would reduce the surface tension of the pink frothy bubbles that they're coughing up, and therefore they would have some relief there in that fulminating pulmonary edema. Absolutely, do not use this if you have an untreated pneumothorax. End of discussion. That is the classic question of what is the absolute contraindication to IPPB or positive pressure in general. There are many relatives. The ones I got in red are the ones that we probably will see a little bit more often being cited. Somebody who has an ICP that is elevated. Somebody who has hemodynamic instability. Do I not do it? Well, you got to take it into account. Am I going to make that hemodynamic instability worse by using positive pressure? Somebody who has active hemoptysis and somebody that has untreated active TB, because again, we're aerosolizing perhaps those secretions that they're going to cough during a cough, and it may be problematic. You can see there are some other ones there as far as nausea and air swallowing. Patients with blebs, because we don't want to create a pneumothorax in the process. Singulation is what? Singulation, the last one on the list, is the fancy name for hiccups. And that's just because you can't time it with them. That thing. So what are we trying to accomplish? Well, we're trying to get a bigger volume. So if we can do it, if they can't do it on their own, we can go ahead and end up doing it. We can deliver medications to have improvement in peak flow. We talked about patients who have an inadequate cough. If I can get a bigger volume of gas into their lungs, I can mobilize secretions and facilitate them being removed. In theory, if they have atelectasis, it should relieve that and have a lung expansion on chest x-ray. We talked about breath sounds, and they should have a decrease in their work of breathing and a level of comfort for them. The primary ones that we're going to talk about using for this, we're focusing on delivering a specific volume. So we want to have some volume measuring device. You've already seen the right respirometer. You guys have played with it that we can end up using. The two that we're going to focus on in the lab here are the Bird Mark 7 and the Bird Mark 8. If you go out into the community and you happen to find a hospital that still has an IPB machine, which is not that common, those are the two that we primarily focus on. So RPE will be done with one of those two units. I grew up on the PR units. This is what they look like, and we'll go through the different controls in a second. And what we're looking to do is have a breath that is positive pressure, and when the breath ends, it ends because it has reached a specific pressure. So we're going to call the process of turning the ventilator on, beginning the flow of gas to the patient, as a trigger, and we're going to call the mechanism that causes that breath to stop a cycle. Okay? I sure can. We're going to call this, and this is the start of the new language you're going to learn over the summer. Okay? Because every breath, every application that a ventilator can do, I can divide into different phases of ventilation. Something's got to start the breath happening. Something's got to initiate inspiration. We call that the trigger variable. Okay. In this case, it happens to be a drop in pressure. When the patient draws in, sucks in a little bit, they create a little bit of negative pressure. That little bit of negative pressure triggers the ventilator to start. Then the flow comes to the patient, and it continues to go to the patient until something else stops it. And in this case, it's pressure. When it reaches a certain pressure that we have dialed in, telling it where to stop, it stops the breath. So this type of ventilation, we're going to go pressure cycled positive pressure ventilation, because it ends when a specific pressure stops it. How did I do? Okay. In the ICU, we have ventilators that operate differently. They may be triggered by pressure, they may be triggered by flow, they may be triggered by time. But here we're just looking at something where it's going to be pressure triggered. And the flow continues until something else cycles it off, and that happens to be pressure also. This is what the unit looks like. This is the Bird Mark 7. We can take a look at a couple things. First of all, there's a flow control in the center. That regulates how much flow is being delivered. And on the sides, there are two little controls there. On the left-hand side is what we're going to call the sensitivity control. On the right-hand side is the control that we're going to call the delivery pressure control. And I'll explain a little bit more about that in a half a second. So, when you turn it on initially, when you plug it into your gas source, you want to have it so the flow is turned off. So you don't have this thing making all kind of noise and whatnot. As I make that flow higher, I'm shortening the inspiratory time. Let me say that again. As I turn the flow up, it's going to reach that pressure quicker. As I make the flow faster, think of it as being more turbulent, whatever, it's going to reach the target pressure sooner. Therefore, inspiratory time will be shorter. If I make the flow slower, I prolong inspiratory time, and it takes longer to get to that target pressure. So what's turning it off? I'm reaching a certain pressure. If I have the flow faster, it's going to get there quicker, shorter inspiratory time. Make the flow slower, it takes longer. I have an increased inspiratory time. Now, on the side where the flow where the flow control is a unitless number. Arbitrarily, we're going to start at 15. Why 15? I don't know, because it's a nice number. Okay, it'll give us. It typically is a flow that is comfortable but not overpowering for the patient. And I can adjust that. What I'm basically targeting is about a 1 to 2 second inspiratory time. Okay, so something that's nice and smooth. Pressure. Pressure is a control that's on the right-hand side of the unit, and when you play with it, you'll end up seeing it. But we're going to start at a pressure of about 15. What a novel idea. 15 and 15. And that's going to allow us to cycle the breath, end the breath, stop the flow when the pressure in the circuitry reaches 15 centimeters of water. That amount of pressure is going to affect how much volume is being delivered. And since our goal here is volume expansion, lung expansion, bigger volumes can be accomplished with bigger pressures. If the volume is too high, I want to back it down, reduce the pressure. Remember when Lori was talking about pressure-based ventilation? Pressure is what we're setting, and what's variable is volume and flow. So the volume that's going to be delivered to the patient is dictated by how much pressure you're using. Randy? It should be 15. not lastly, the next control we have is the sensitivity control. This is on the left side of the box. And normally you want to have it somewhere between -1 and -2. It's, again, a unitless value. In a proper calibrated machine, which for your PEs, I'll make sure they all are, if you put it at 15, it's about a 1.5 centimeter of water, a 1.5 centimeter of water pressure drop that is required to turn the machine on. Sensitivity tells us how easy it is or hard it is to begin the breath. Remember I said there was a drop in pressure at the beginning? That trigger, the more, okay, let me stop there and let you guys catch up to me. If I were to say that I make that sensitivity more negative, so instead of being at -1 or -2, it's at -10. That means it requires more effort to turn the unit on, and we say the sensitivity is decreased. Seems awkward, okay? It's harder to turn on because the number's bigger. If it's less negative, it's more sensitive, it's easier to turn on. I can make it so insensitive that I actually can lock the patient out. I don't care how much you draw back, you ain't turning this machine on. Well, that's just cruel and unusual punishment, but theoretically you can end up doing it. You can actually lock them out. On the other end, I can make it so sensitive that it triggers by itself. We call that auto-triggering. That's not a desired effect. We want to be just sensitive enough that it requires a little bit of effort on the part of the patient, but it's not so sensitive that it turns itself on. Flow, pressure, sensitivity. Used to have a T-shirt that said respiratory therapists to do with pressure and sensitivity. Yeah. It was an old joke. Okay. So, first thing we're going to end up doing is, again, setting the flow to 0. Setting our pressure value and our sensitivity to 15. Then go ahead and turn it on by setting the flow to 15. And then we're going to talk about the air mix control in a second. I occlude the outlet and I make the sensitivity either more or less sensitive by just allowing it to auto trigger and then backing off from there. So if the auto trigger is happening at, say, -0.5, go ahead and make it a little bit more insensitive so it triggers. And we'll go through a demo of this when the time comes. This is the piece of equipment that I learned on. It was called the Puritan respirator, the PR. PR1, PR2, and a lot of fun times with that. Puritan Bennett also made a home unit. It was called the AP4 or AP5, and just for informational purposes, it was electrically powered and allowed the unit to function. All right. Another component of the circuit of the IPB delivery is that we have to have an IPB circuit. And this is basically attached, the one end on the right-hand side here attaches to a filter, which attaches to the unit itself. This tubing then has 2 drive lines. And there's a little jumper cable that goes between the two. So this is my exhalation valve. This is my nebulizer. During the inspiratory phase, I want to have 2 things happen. I want the nebulizer to start nebulizing. I want to be able to have medication being delivered to the patient. And the second thing I want to do is I want to close that valve. The little jumper cable will end up allowing us to do both. And again, when I go through a demo on this, then it will probably make a little bit more sense. And then after the exhalation valve, I have a small corrugated tubing. and a mouthpiece. And when we get to that point in time for the PE, we'll demonstrate what we need you to do for that. Some other stuff that you may need, some nose clips if the patient happens to be breathing through their nose. We can use other applications other than a mouthpiece for patients that may have not good lip control. Or we can use a mask, or if they're intubated, we may end up having to use 50mm adapters to attach to the endotracheal tube. We're going to use some medication. For our purposes in the lab, when we're doing the demo, you're going to end up using just normal saline. We want to have something to measure how much volume we're using. So on the expiratory port, right here, where the patient exhales, I'm going to put a respirometer on there to see how much volume they're taking in, and all the other stuff that you may end up using. This is the mouth seal. We used to call it Bennett seal. That basically, if somebody's got, they're aged and they just can't use their lips, keep leaking, using a mouthpiece to seal it, or a mask, or to an endotracheal tube. So again, here's my little jumper that I was talking about. As positive pressure pushes, it not only causes nebulization to occur, but it's also causing that exhalation valve to remain closed. During exhalation, then, there's no pressure on that valve, so then the patient's allowed to exhale back out through the expiratory port, and this is where I would hook up my respirometer to. And I'll go ahead and I'll do a quick demo on this. I don't know if we'll do it after class today or if we'll do it next Monday, but one of the two we'll end up doing. And part of this is we're going to learn how to use these red test lungs, because you're going to hook them up and you can adjust compliance and resistance by adapting them. I'll have it set up in the proper settings, so you won't have to worry about playing with it, but we normally use a two resistors, one of 5 and one of 20, and we use our compliance, which is along the side. We would set at 0.05, excuse me. So how does this unit work? How does the Bird Mark 7 work? Well, it works on the concept of pressure versus magnetism. Has a magnet on each side that's pulling on a little piece of metal, and depending upon the pressure, it's going to either it's going to either turn the unit on and allow flow to go through it, or it's going to turn the unit off. Here you can see where it's on the left-hand side, gas is flowing to the patient. On the right-hand side, then the patient is exhaling. So at a no-flow state, the pressures on either side of the chambers are equal. They're atmospheric, let's say. Okay? And what determines which way it goes is the pull of the magnet along there. So, patient now has their mouthpiece in, they're going to take a breath in. Depending upon that sensitivity, when the pressure here becomes negative enough that the pull of this magnet pulls it away from the magnet on the other side, which we set by setting that sensitivity control, it's going to go ahead and allow the gas flow to begin to go to the patient. This portion in the center is called the ceramic switch, and on it, it has 2 metal clutch plates. The metal is obviously what the magnet is pulling. So when I pull it to the right, gas flow begins. It doesn't sound like that, but you get it. As the pressure rises on the right-hand side, the magnet on the left is going to be enough to pull it back the other way. So as the pressure builds, it's pushing that ceramic switch to the left, and the breath ends. So once it reaches our target pressure of 15, it's got enough pressure that's pushing that clutch plate, that piece of metal, away from the magnet on the right, and it shuts itself off. And I'm probably making no sense at all, but that's okay, because you're not paying attention anyways for now.
So I assume those are electromagnets then? Because if not,
There is no electricity.
then how come when it's attracted to one side, when we turn it off, why doesn't it just stay there?
It does, because the pull on the left-hand magnet is strong enough that it's not causing the ceramic switch to move back.
Okay.
You'll see when I do a demo on it, which is, again, I think I'll save till Monday. So what we're going to go ahead and do is set this up on a test lung, and then we're going to see what happens when I change compliance and resistance. What happens to the delivered volume? Because remember, a pressure-based breath, volume is variable. What causes it to vary? Well, the level of pressure we said did, but also the compliance and resistance of the lungs changes that. As compliance falls or resistance goes up, less volume is delivered because it's taking more pressure to get there. We'll also play with the sensitivity to make sure that it's not auto-triggering or it's not locked out. And this is how we would solve that, by adjusting the magnet closer or further away from that clutch plate. And since we're going to be using oxygen, there's what is called an air dilute control, and you'll see this when you look at it. You either push it in to get 100% or pull it out to get something less than 100%. And we'll talk more about that when we're playing with it, but it also alters the amount of back pressure and the FiO2 that is there. So we'll actually talk about that later. Okay. This is just when we go through the process, we'll go through and see what happens if I have a higher resistance, a loss of compliance, or an increase in compliance. What happens in each instance to what volume is delivered. And hopefully that will solidify a little bit about what's going on here. So for your performance eval, again, we're going to probably using the Bird Mark 7 or Bird Mark 8, and you're going to be giving a treatment. I believe, Amber, is that correct, that they do it on us? On test lung, okay. So we won't be using anything in the nebulizer cup itself, because I don't think my test lungs need to have saline put into them. But just some of the things that we end up using as far as that, rinsing those cups out. Now, this slide I wanted to put a star by because you're going to come back and revisit this over the summer. Positive pressure ventilation, regardless if we're talking IPVB or we're talking mechanical ventilation, or we're talking non-invasive, all have these similar complications and hazards. First of all, they can promote barotrauma in patients who have weak lungs. Somebody who's got a blub or a bullseye, higher risk of that positive pressure blowing that. I think you have a case study on something about a pneumothorax. We can have the patient develop tingling in their fingers, lightheadedness, dizziness, simply because we're blowing off too much CO2. Okay? It's not the medication that's causing it, it's just the technique. You can see the same thing with incentive spirometry. You can see the same thing with a small volume nebulizer. If the patient's breathing too fast, they're going to blow off CO2, and you'll get that tingling in the fingers and lightheadedness, etc. Big problem. Not so much with IPVB because we're not using higher pressures, but when we get into mechanical ventilation, as I put positive pressure into the chest, the normal mechanism by which venous blood returns to the thorax is a negative intrathoracic pressure. I take a breath in, that negative pressure not only draws in air, it also draws blood back to the thorax. Did what I just say make sense? Okay. If I substitute positive pressure, I take away that. Don't have blood coming back, don't have preload, don't have cardiac output. So I can cause a drop in blood pressure simply by using positive pressure. So one of the first things we're going to do after we place a patient on a mechanical ventilator over the summer or a non-invasive ventilator is we're going to monitor their blood pressure. Like I said, we don't see that effect as profoundly with IPVB, but it is a potential that is there. You can also see air trapping happening, and we see this in patients who have airflow limitations, say COPD or asthma. We don't allow enough time to exhale, they trap the gas. And that can lead to really, really huge problems, as we'll talk about summer and fall. Okay, I'll walk through the procedure when we get done, and we'll talk about some documentation, same as you saw with small volume nebulizer, with the exception now that we're also monitoring the volume, because I want to make sure that the volume expansion component of it is being met. 2 to 3 times the spontaneous tidal volume, vital capacity is above 15 mLs per kilogram. There is a sheet in your folder that goes through troubleshooting. Failure to trigger the ventilator on would be a sensitivity issue. Or if it's triggering itself on, is a sensitivity issue. Failure to turn the unit off means I can't reach to target pressure. More often than not, it's a leak in the system. If I have a leak, I'll never reach that target pressure. And oh my God, yes, there is a protocol there. This is talking about different components as to which do I use, incentive spirometry, do I use IPVB? We haven't talked about PEP therapy yet, but that's another option that we end up having. So here I have, let's go through kind of some examples. Somebody with quadriplegia. They can't take a deep breath because they don't have the musculature there to do. So I want to be able, he's got atelectasis. He's probably not going to be able to do incentive spirometry by himself. So using an IPVB, in this case with a mouthpiece, if he can't keep a seal, we have a mouth seal or a mask. He has reduced inspiratory capacity. Which control would be adjusted to increase the volume? If you don't know, it's pressure, and to some extent flow rate. How would you adjust these settings? Increasing the pressure would increase the volume. Reduce the flow would lengthen inspiratory time. Because I'm exposing that pressure for a longer time, volume would go up also. Got it?
There's no way to control exhalation time?
We control expiratory time by controlling inspiratory time, because patients are triggering this on typically.
Okay.
Having difficulty in initiating inspiration, which control should be adjusted? Can't turn it on? Okay, don't answer. Sensitivity. You make it less sensitive, it's easier for them to turn on. Hold on a second, I got another one for you. During IPB, the gauge is rising very slowly. Whenever you see something where the patient isn't getting the breath fast enough, we need to turn the flow up. You will find that in many, many instances, the answer to the question is turn up the flow. Patient complains of lightheadedness, paresthesia. What's paresthesia? Tingling, the fingers. Headache during incentive spirometry. What would you do to correct it? Slow your butt down. They're hyperventilating. Patient with COPD who has oxygen-induced hypercapnia. How would I want to do? Well, how about if I administer the treatment with room air? Don't use oxygen to power the unit. We can hook it up to a compressed airflow meter just as easily. A bird is noted to be stuck in the inspiratory position. 3 causes of the problem. Well, I said leak. Leak, leak, leak. Leak in the circuitry, leak at the patient connection, or through their nose, or I got an exhalation valve that needs to be replaced, that's damaged. And as I go through the demo of it, you'll see what I'm talking about. During IPV therapy, a patient complains of sharp left-sided chest pain. Hey, that sounds like a case study. Cyanotic and dyspneic, what are we going to assess? Well, first of all, I'm going to stop the therapy because this patient is not doing well. I'm going to administer oxygen and notify the nurse and physician. And listen for breath sounds. What would you anticipate breath sounds sounding like if I had a pneumothorax?
No.
They're absent. What about diagnostic chest percussion?
Hollow.
Hyperresonant, right? Hollow sounding. And palpation, what would you, if you suspected a tension pneumo, what would you palpate?
PMI and then
The tracheal shift, right. And it says real incentive spirometry, and if you reach 2,000, we won't let a student draw your blood gases. That's the incentive. All right, let's do this.